So let's start our discussion on cerebral palsy. First of all, as we all know, cerebral palsy is a condition that is related with pediatric department. It is related with the pediatric case, and cerebral palsy is a condition that is completely generally related with the motor function disability. In cerebral palsy, generally what we see the motor function disability in the patients, and it is a group of disorder. It basically shows a different symptoms, different it has an extent of symptoms, it has a very large extent of symptoms. Okay, so it is a group of disorder of posture. It is a group of disorder of posture and movement. Apart from the posture and movement, many other stuffs can also be linked with the cerebral palsy that we will deal later. But here, if we define cerebral palsy, it is basically a group of disorder that is related with the postural abnormality, that is related with the movement or any motor ability, and this all can be due to the damage of the developing fetal or the infant's brain during the developmental life of the fetal, during the developmental life of the infant in the mother's womb. There can be any damage to the child's nervous system directly or indirectly, and it can lead to the cerebral palsy. Apart from the developmental injury, any birth injury can also be lead to the cerebral palsy, or after the birth, if there is any injury or if there is any infection in the children, then it can also lead to cerebral palsy. We will discuss about the etiology and the risk factors later, but in this session we will mainly focus on the assessment and the physiotherapy management for the cerebral palsy. We will not dive deeper into the pathophysiology or everything or etc of the cerebral palsy. Our main focus will be on the assessment and the management of the cerebral palsy. Okay, now cerebral palsy is a non-progressive disorder. Non-progressive disorder, it doesn't progresses as the day passes. It is a non-progressive disorder that involves a broad spectrum of motor disability. I already told you that cerebral palsy is basically related with the motor function disability. Mainly motor functions are disturbed in the cerebral palsy. Okay, okay, so apart from the motor disability, what other problems can we see? We can see some problems related to the cognitive function. Seizure, it can be a complication in the cerebral palsy, but apart from the cognition level, vision abnormality can be seen, speech abnormality can be seen, any abnormality with the swallowing can be seen, orthopedic deformities are also visible in the patients of cerebral palsy. So these are some other problems that can be associated with the cerebral palsy. Now, if we talk about the risk factors and the etiology of the cerebral palsy, so the risk factors and the etiology can be classified into three groups. First is the prenatal, second will be the perinatal, and the third will be the postnatal. Here in the prenatal, first is the torch infection. What is the torch infection? It is a short abbreviation. Its full form is T for toxoplasma, O for others. In others, it can be syphilis or hepatitis infection, R for rubella virus infection, C for cytomegalovirus infection, and H for herpes simplex infection. So if the mother during the pregnancy, if the mother is having any of these infection, whether it is in the infection of the cytomegalovirus, whether it is infection of any toxoplasma virus, so it can lead to the developmental abnormality in the child that can further lead to the cerebral palsy. Apart from the torch infection, hypoglycemia is one of the very important and major cause that we can see nowadays. Apart from hypoglycemia, RH incompatibility, it is also a very major risk factor. When there is RH incompatibility between the mother and the fetus, it can lead to a condition that is called erythroblastosis fetalis, and erythroblastosis fetalis can lead to the cerebral palsy. It can lead to some damage in the nervous system, in the developing neurons of the child. Apart from the placental abnormalities, drug side effect can be seen in the mother who are on any drug therapy. For example, if any pregnant woman is suffering from epilepsy or seizure, and she is having the anti-epileptic drugs or any sedative or hypnotic drugs, then it can lead to some abnormalities in the developing child's brain, and further it can lead to the cerebral palsy. Then, if you talk about the perinatal risk factors and etiology, the preterm delivery is one of the very major cause of the cerebral palsy in the perinatal sector. It means the delivery before the due date is termed as the preterm delivery. The child's brain and the child's system is not well developed, and the child get delivered. So in that case, the cerebral palsy can be seen. Then the carotid artery occlusion during the birth. If during the birth, due to the prolonged labor, the muscles start to contract. due to the prolonged labor, the carotid artery of the child can be compressed. It can be compressed, and due to the compression of the carotid artery of the child, it can further lead to the asphyxia or the ischemia in the brain, and it can further lead to the cerebral palsy. Apart from that, this IC or MC Augulson, trauma, asphyxia, and neonatal meningitis. This is also very common nowadays. Neonatal meningitis can also be called can also lead to the cerebral palsy. Then postnatal cause includes the delayed cry. If there is delayed cry, then the condition can then the cerebral palsy can be seen. Jaundice, trauma, and infection can include meningitis, encephalitis, jaundice, etc. These infections can lead to the cerebral palsy. Now, what are the classification of the cerebral palsy? CP can be classified on different bases. First is the topographical distribution, and second will be the distribution, the classification depending upon the muscle tone. On the basis of topographical distribution, we have four types: the monoplegic type, diplegic type, hemiplegic, and quadriplegic type. And depending upon the muscle tone, we have spastic CP, we have dyskinetic CP, we have ataxic CP, and we have mixed CP. Dyskinetic CP is also called athetoid CP. The other name of dyskinetic CP is athetoid CP. Okay, now let's discuss these all types one by one in short. First of all, spastic CP. This spastic CP is very common. About 70 to 80% of the cases are the spastic CP, and in a spastic diplegic CP is very common. Okay, in a spastic CP, the cerebral cortex gets affected, and the voluntary controls are also affected. The child doesn't able to do any voluntary movement. He or she doesn't control on his voluntary movement. And in a spastic CP, there is a condition. There is very tightness in the adductor muscle. So due to the tightness of the adductor muscle, it can cause the seizuring type of gait. Seizuring type of gait can be seen in the patient of the spastic CP because of the tightness of the adductor muscle. And here the deep tendon reflex will be present, will be increased, clonus will be present, and the muscle tone will be very high. The muscle tone will be very high. Hypotonia will be present in the spastic CP. Then weakness, pathological reflexes can be seen. It is same as the deep tendon reflex, increased deep tendon reflex. Here Babinski sign will be also be positive. And spastic CP has further three subtypes: quadriplegic, diplegic, and hemiplegic. Now let's discuss about these three types. I think you all know this is the somatomotor homunculus of the human brain, and in the human brain our body is organized in the upside down manner. For example, this is the right side of the cerebral hemisphere. This is the right cerebral hemisphere, and here it is the left cerebral hemisphere. For example, if there is any damage in the right side, and only this region, if only this region is affected, and we can see that this region is responsible for the supply and for the motor control of the lower extremities of the leg. So if there is only damage, if there is lesion only in this region, what will this lead to? Since this is the right side of the cerebral hemisphere, so this will lead to the problem in the motor function of the left side of the body, especially in the lower extremity, because this area is only related with the lower extremity. Okay, so now this condition will now what will be this condition? This condition will be, in this condition only the lower extremity of the left side will be affected. Now same, if this lesion also occurs in the left side too, then the lower extremity of the right and left both sides will be affected. So in this manner so in this way we can study about the pathophysiology of the cerebral palsy. Now the next one is dyskinetic CP. Dyskinetic CP can also be called the athetoid CP. It is also called athetoid CP. It is the second most common case apart from the after the spastic CP. The mostly seen is a dyskinetic CP, and dyskinetic CP is due to the injury in the basal ganglia. Now, as we all know, basal ganglia is a part that is mainly responsible for the voluntary control. Its major function is the voluntary control. So in dyskinetic or athetoid CP, there will be complete loss of the voluntary movement of the child, of the patient, and here unwanted movements, some jerky movements can also be seen in the patient. Clinical diagnosis can generally occur within 18 months in the case of dyskinetic CP. Now ataxic CP, it is due to the injury in the cerebellum, and we all know cerebellum is a part of the brain that is mainly responsible for the control, for the balance, and for the coordination of any person. So if there is any injury in the cerebellum of the patient, then it will lead to the loss of balance, it will lead to the loss of control and coordination of the child. the child will not be able to control his or her posture, and because of this wide base of support is seen. When the posture is unstable, the child will attain a wider base of support to keep his or her body upright, to he or she will try to balance his or her body with wider base of support. And this ataxic is generally diplegic. In the ataxic, hypotonia emerges. It means the muscle tone will decrease, and it is the least common among the spastic CP, among the dyskinetic CP and ataxic CP. This is the least common type of CP. Now this was the basic introduction. Now let's start our main topic, that is the assessment for the cerebral palsy. In the case of cerebral palsy, how we can assess, because assessment is one of the very important step in the treatment of any person. If we initiate the treatment of any person, first of all we have to do assessment, because after doing a perfect assessment we can make a perfect treatment protocol for our patient. So for assessment, initially we have to take for the initially we have to go for the demographic data of the patient. What is the age of the patient, what is the name of the patient, address of the patient, it is. Then the chief complaint, and then our main point is the history. We have to check for the history, we have to go for the history. Now again, in history, first of all we have to check for the prenatal history. Prenatal history, it means the history of the mother during the it means the history of the mother. Just a minute, someone is trying to enter. Okay. Prenatal history means the history during the pregnancy. It is the history of the mother during the pregnancy. So we have to check for the mother's age first of all. Then the drugs used during pregnancy, during the pregnancy period, during the gestation period, which drugs was being consumed by the mother. We have to check for these drugs, because many drugs create a great influence on the developing child, especially the CNS depressant drugs, the anti-epileptic drugs, the anti-anxiety drugs, the sedatives, hypnotics, barbiturates, benzodiazepines. These drugs are very much responsible for the depressing of the developmental brain of the child. That's why we have to check for the drugs that are being used during the pregnancy. Any infection during the pregnancy, as I have already told you in the etiology, that there is an infection, that is torch infection. Okay, so torch infection is very much seen in the case of cerebral palsy. So we have to check for any of these infections during the pregnancy. Any medical condition of the mother, if the mother is having any medical condition like hypothyroidism, or hyperthyroidism, if the mother is having the diabetes mellitus, or any heart condition, or any medical condition, or any past history of abortions or ectopic pregnancies. We have to check for the past history of abortions and the ectopic pregnancies. After the prenatal history, we have to go for the perinatal history. In the perinatal history, we have to check whether the delivery was normal or it was the preterm delivery. Okay, then the labor duration, history of asphyxia and birth cry. These two are related. Birth cry, why birth cry is important in the perinatal history? Because when the after the delivery, when the child cries, it is the initiation of the respiration of the child. If the child has not cried, it means that the respiratory system has not been activated, the child is not breathing, and due to the loss of breathing, the cells of the brain can start to necrose, and it can lead to the cerebral palsy. Okay, after the perinatal, we have the postnatal history. In the postnatal history, we have to first check the Apgar score. This postnatal history, this is the history, this is the assessment for the child. At first we had discussed about the prenatal. The prenatal was all about the mother, but here in the postnatal, this is all about the children, or all about the child. So in Apgar score, it is just checked after the birth of the child. Here we will check the appearance of the child, the pulse or the heart rate of the child, the reflex of the child, all the neonatal reflexes of the child should be checked here. Then the activity, or we can also check for the muscle tone here, and the respiration of the child. These five stuffs are being checked in the Apgar score, and if the score is between 7 to 8 or 9, then it is very normal, then it is very fine. Okay, after that, trauma, any birth injury should be checked, should be assessed during the postnatal history. Any diseased condition, whether the infant is having any infection or any diseased condition, the nutritional habits, any surgical condition, or any medical history of the patient. Okay, after this postnatal history, we have to go for the observation. In the observation section, first of all, we will check for the child alertness. Is the child is alert or not? Then communication, is the child is able to communicate or not? Is he or she is understanding what we say? He or she is responsive or not? Then the postural alignment, what is the postural alignment of the patient? Is the patient able to control his or her posture? Is the muscle tone is normal or not? We have to observe for these all. Any deformity, if there is any orthopedic deformity seen in the patient, generally in the spastic CP, the TA tendon is very stiff, and it will lead to the equine position of the patient. So we can check for the deformity, any orthopedic deformity is seen or not in the patient. Then involuntary movements, when the basal ganglia is involved in the lesion, it can lead to the loss of voluntary movement, and it can also increase some jerky abnormal movements. These all are involuntary in nature, so we have to check for the involuntary movements. And then scar and tremor, if there is any tremor or scar present on the skin of the skin of the patient. Then in the examination, we have to check for the orientation. Is the child responsive, or is he or she is unresponsive? Is he or she is understanding our is he or she is understanding what we are saying or not? Then vision, we can check for the vision assessment. Hearing, speech, cranial nerve assessment. Actually, vision, hearing and speech can be assessed through this cranial nerve assessment. Okay. Then sensory examination. Sensory examination is also very important. Sensory examination, in the sensory examination, we can go for the superficial sensory examination, like the touch, like the pain, like the vibration, like pressure, etc. Okay, so we have to go for the sensory examination. And now reflex examination. In the child, in any pediatric assessment, this reflex assessment is very important. Reflex assessment plays a very important role in the assessment of any pediatric condition. We have to check for the flexor withdrawal reflex. We have to check for the palmar and plantar grip, sucking and rooting reflex. These all are being mediated by the spinal nerves. Then tonic labyrinthine reflex. This tonic labyrinthine reflex is generally seen for the flexor and extensor tone. We have to check for the flexor and extensor tone, we can go for the tonic labyrinthine reflex. Then ATNR and STNR, this is asymmetrical tonic neck reflex and symmetrical tonic neck reflex. These two can be checked, can be assessed in the case of cerebral palsy. In the asymmetrical tonic neck reflex, for example, if the patient is in supine position, we will turn the head of the patient to the right side. If we turn the head to the right side, then the right arm of the patient will extend and the left arm will flex. I am repeating this. In the asymmetrical tonic neck reflex, if we turn the head of the patient to the right side, then the right arm of the patient will extend and the left arm will be flex. And again, if we turn the head to the left side, the left arm will extend and the right arm will flex. So this is the asymmetrical tonic neck reflex. This is only related with the head and upper extremity. But symmetrical tonic neck reflex, this STNR, it is related with hand, it is related with head, with upper extremity as well as the lower extremity. In symmetrical tonic neck reflex, the patient is in supine position, and if we flex the head of the patient, if we flex the just a minute. Okay, so in the symmetrical tonic neck reflex, if we flex the head of the patient, if we flex the head of the child, then arm will also be flexed automatically and leg will extend. Okay, if we flex the head of the child, the arm will also flexed, both the arms will flexed and both the legs will extend. Now again, if we extend the head of the patient, the arm will also extend, but this time the legs will be in the flexion mode. Okay, so this is how we can check for the asymmetrical tonic neck reflex and the symmetrical tonic neck reflex. Okay, so after the assessment of reflex, we have to go for the tone, muscle tone. We have to check for the muscle tone. We have to check for the spasticity or rigidity of the patient, hypertonia or hypotonia of the patient. Then muscle weakness, the voluntary control, the assessment for the voluntary control. Balance and coordination. Balance and coordination is very much important in the case of cerebellum injury. In the case of the ataxic CP, these two can be assessed, because in the case of the ataxic CP, the coordination and balance is highly affected. Apart from the motor disability, the coordination and balance is also highly affected. Then range of motion of the patient, and at last GMFCS, it is gross motor functional classification system. This gross motor functional classification system is only used in the case of of CP. Here we can conclude the extent of disability of the patient. So GMFCS, it have a score ranging from score 1 to 5. Then what is the conclusion of GMFCS? If the patient is able to walk without any limitation, if our child is able to walk without any limitation, we will give him the score 1. If the patient is able to walk but with some limitations, then we can give the score 2. If the patient is able to walk but with any handheld mobility device, he or she needs some handheld mobility device for walking, then we can give the score 3. If self mobility is restricted, self mobility is very limited in the patient, then we can give the score 4. And in the score 5, the patient is completely either bedridden or on the wheelchair with okay. So these are the 5 score of GMFCS. I am repeating again. Score 1 means the patient is able to walk without any limitation. Score 2 means the patient is able to walk but with some limitations. Score 3 means the patient is able to walk but with handheld mobility device. Score 4 means the self mobility of the patient is very restricted, very limited self mobility is seen. And score 5 means the patient is completely restricted to the wheelchair or the bed. Okay. So these are the 5 stages of these are the 5 classifications of the cerebral palsy on the basis of the disability, on the basis of the extent of disability. Now after examination, we have to move on for the management. Now, in the management of cerebral palsy, it takes a longer duration. CP patient demonstrate a various of issues and defects throughout their life. Throughout their life, there can be some changes in the symptoms. There can be some changes in the defects of the patient, and for this all we have to be ready. So, for the treatment of the cerebral palsy, 4-stage treatment is given to the CP from infancy to childhood. From infancy ranging to childhood, we have to give the treatment in 4 stages. First is the early intervention. Second is the preschool. This is the stage 2. Stage 3 is the school age and adolescence, and stage 4 is the adulthood. So we have to give the treatment. We have to manage the CP in these 4 stages. Let's discuss all these 4 stages one by one. First of all, for the early intervention, positioning of the child is very important. Positioning of the child in supine, promote the head orientation in midline. If we are positioning the child in supine line, it can also it can help to promote the head orientation in midline. Then in the supine position, we can also go for reaching activities. Positioning of the infant in prone, we can also keep the infant in prone lying, but prolonged positioning in the prone lying is not recommended because it can also cause some respiratory distress to the patient. Okay. Then active head lifting in prone, we can train for the active head lifting in the prone by the patient. Active extension in the prone, that is active extension in the prone can also be done with the patient, like the uh, prone and elbow, prone on hand, etc. Infants should not sleep in prone. As I have already told you that infants should not sleep in prone, and we have to not keep the prone. We have not to keep the infant in the prone for a longer duration, because it can lead to some respiratory problem. It can lead to some respiratory distress to the patient. Then sitting and standing, flexed posture of the patient facilitates feeding. Deeper respiration can also encourage by applying slight pressure at the thorax abdomen prior to the inspiration. Okay, when the patient is breathing, before inspiration we can apply slight pressure on the thorax or the abdomen. It can encourage the respiration, it can encourage the respiratory muscles to do more work. Then gentle ROM movements, functional activities can be done. And reaching, I have already told you that reaching can be done in the supine, or we can also do the reaching activities in the sitting or in the kneeling position. Okay. Apart from this all, we have take the proper precaution, because dislocation can occur. Dislocation of some joints can occur in the case of cerebral palsy, especially in the case of the shoulder joint. Especially in the case of the shoulder joint, the dislocation can occur. Okay, so we have to take care for this dislocation. Then trunk flexion on the physio ball, we have to use the physio ball for the treatment of the patient. And on the physio ball, we have to do different activities, like the activity of trunk flexion. We can do rolling activities on the physio ball. We can uh, Please turn off your mic. I don't know whose mic is open. Okay, so on the physio ball we can do different activities like the trunk flexion, like the trunk extension exercises. Then we can also do rolling exercises or rolling activities on the physio ball, some jumping activities on the physio ball. So we can use physio ball for different activities, and we have to keep in mind that we have to do some functional activities like some playing activities too with the patient. Then sit to a stand. Stretching is very important in case of the spastic CP. As I have already told you that many patients have the very stiff and very spastic TA tendon, so we have to stretch for the TA and calf muscles so that the patient's gait can be improved. It can also lead to some improvement in the gait of the patient. Then CIMT, constraint induced movement therapy, can also be used. Splinting and task oriented approach. This task oriented approach is very important, as I have told you, because task oriented approach creates a positive feedback into the brain of the patient, and it can also helps in relearning. It can also help in the motor learning of the patient body parts. Okay, so task oriented approach is very important. Now in the preschool or the second stage, just keep in mind that we are starting preschool. That means we will not stop all the exercises of the early intervention. The early intervention exercises will go on along with, we can start the preschool in the second stage. Here in the preschool, our major emphasis during this period is to promote mobility and functional independence. Here the main goal will to promote mobility of the patient and some functional independence of the patient. Okay, here activities will include promoting postural reactions to improve head and trunk control. In the case of CP, the trunk muscles, the head muscles, the neck muscles are very weak, so the patient cannot sit upright from his or her trunk. So we have to improve the trunk and the neck muscles, and we have to focus on the postural abnormalities, and we have to check for the postural reactions of the patient. We have to teach for the transition and practice of self care skills. Transition means the transition between sitting to supine, from sitting to standing, from supine to prone, from supine to sideline. These transitions can be taught in this stage, in the preschool stage, along with some self care skills. Then if the child didn't achieve upright orientation and mobility during the early intervention, now it's time to make a concentrated effort to make them do so. If the child in the early intervention, if the child didn't achieve the upright orientation, if the child didn't achieve some mobility, then in this stage, in the preschool or in the second stage, we will try our best to give the patient an upright orientation and a proper mobility. Okay, now after this we have to we can also use some assistive device or orthotic device. Some orthosis can be used, like ankle foot orthosis can be used in the patient. Supramalleolar orthosis can also be used in the patient. Okay, we should also start focusing on the ambulation of the child. As we have already discussed later, as we have already discussed that in the case of cerebral palsy, gait is also highly affected. The seizuring gait can be seen in the spastic diplegic CP, or in the most of the spastic CP, the seizuring gait is commonly seen. So in this stage we have to work for the ambulation of the patient. We have to work for the gait of the patient. For gait of the patient, we have to go for stretching, we have to go for the strengthening exercises, and some other exercises too that we will discuss in the next slide. Gait difficulties include limited postural reactions during wet shifting, decreased single limb and double limb support time. In the gait, if we assess for the gait of the patient, if we assess for the gait abnormalities, if we check the different events of the gait, different parameters of the gait, then we will get to know that the postural reactions during wet shifting is not good. The patient is not able to shift his or her weight from one leg to another weight. Then from one leg to another leg, then single limb and double limb support time is highly reduced. Okay, so if child cannot support body weight in standing or during sit to stand transition, then a part of child body weight is given on extended arms and the child practices coming to stand. Let's understand this point with this image. Here in this image we have to use a bloster. On the bloster the patient's leg will be stabilized by the therapist like this, and here see the upper trunk weight of the patient has been given to the hand. Here the hand muscles, the arm muscles are also involved in the weight bearing exercises, and since the upper trunk weight is given to the hand, now the patient will try to stand with this support. Okay, so here this is written, if the child cannot support body weight in standing, if the child is unable to support his or her body weight, if the child is unable to maintain his or her body weight during the standing or during the sit to stand transition, then a part of child body weight is given on the extended arms. Here the upper trunk body weight is given on the extended arms of the patient, and the legs are being stabilized by the therapist. Now the patient will start the now the patient will try to now the patient will try to do some movements. Okay, now after this, Trunk laterally bend a trunk lateral bending may result in lower extremity separation, as during the weight shifting opposite leg is automatically abducted. Now, since the adductor muscle is very tight, since the adductor muscle of the patient is very stiff, and the trunk muscles are also very loose, they cannot work easily. So in this condition what we can do, trunk lateral bending, we can go for the trunk lateral bending like this. Here the patient is in sitting position. Now we will do the lateral bending of the trunk. Whenever we do the lateral bending of the trunk, automatically the opposite side leg will go in abduction. Okay, we have to go for the lateral bending of the trunk, and whenever we go for the lateral bending of the trunk, it will then the opposite leg of the patient will go into abduction. Okay, so we can go for this too. Now, pushing a toy and weight shifting, we will ask the patient to, just a minute. Okay, we will ask the patient to push some toy. We will give some balls to play, and weight shifting we will also train for the weight shifting. As the child maintains the time for double limb support, progression can be made. In the early slide, in the last slide, we had discussed about the gait analysis. During the gait analysis, we have discussed that the double limb support and the single limb support time has been reduced. So after, as the child maintains the time for the double limb support, we can progress the gait analysis, we can progress the gait training by stepping over an object. We will keep some object in front of the patient, and we will ask the patient to step over the object, and stepping up and down on the stairs, this can also be done. Having a child hold on the vertical poles decrease the amount of support and facilitates upper trunk extension. Okay, like this, as the diagram shows, we have to ask the patient to hold two poles, and then the patient will try to balance his or her body. This will decrease the amount of support and facilitates upper trunk extension. Here upper trunk has been extended, and we have to go for such activities to to facilitate the upper trunk more. Okay, now many children can benefit from using assistive devices like rolling reverse walker. During the gait training, we can also go for some reverse walking. And since the patient is not able to control his or her body, his or her muscles and the body parts, we can go for some assistive device that can be used for the reverse walking, like the rolling reverse walker during the gait training. Here the patient will walk in the backward direction. Now, next stage is the school age and the adolescent or the adulthood. This is stage 3 and stage 4. I have included these both stages here. Now again, if we are having the stage 3 and stage 4 of the patient, then it doesn't mean that we have to stop all the exercises of stage 1 and stage 2. Some exercises according to the patient disability, some exercises will go on. Along with, we have to go for the stage 3 and stage 4. In stage 3 and stage 4, the role of family and the society increases. In the stage 3 and the stage 4, the role of society increases. Here we have to remember 5 F's in the stage 3 and stage 4. First is function, then family, fun, fitness and friends. So in stage 3 and stage 4, there is a great influence of the society, there is a great influence of the family along with the friends on the patient. Apart from the therapist, the patient Okay, so apart from the therapist, the family, the environment makes a great influence on the patient in the stage 3 and stage 4. So in this stage, we have to ask the patient for some social interactions. We have to ask the patient for any for any economic for any social interactions. Now here in 3 and 4th stage, psychological management can also be needed in many patients. Okay, so if needed, psychological management, psychological counseling can also be provided to the patients. We should focus on the continue independent mobility and activities of daily living. We are focusing on the mobility since the stage 1 from the early intervention. That's why I have told you, if we are having the stage 3 and stage 4 of the patient, then we cannot stop all the exercises, all the treatment protocols of the stage 1 and 2. Some exercises according to the patient's disability will go on to the stage 3 and stage 4 too. So here we have to continue on focusing the mobility and the activities of daily living of the patient. We have to make the patient more independent, because now the patient is having because now the patient is interacting with the society. So the next is the community and the social interaction. As I have already told you that social interaction is very important in the stage 3 and stage 4 patient, for the proper growth of the brain, for the proper brain growth. Okay, now apart from this all, if we have any case of a spastic CP, now how we can manage the spastic CP? Because spastic cerebral palsy is most common. Mainly spastic CP is seen about 80 to 90% cases of the cerebral palsy are of the spastic type. So for the spastic CP, we have to focus on the mobility in all the possible posture, and the transition between this posture. Transition between the posture, it means the transition between the sitting to standing, from a standing to sitting, from sideline to supine, from sideline to prone, from supine to prone. These all transitions can help to achieve more mobility in the patient. The superficial receptors will also stimulate during the transition of these postures. Okay, now since it is an spastic type of cerebral palsy, so stretching is much needed. So stretching is much needed in this type. Here the most common tightness area in the quadriplegic case is the shoulder adductors, elbow flexor, wrist flexor, and finger flexor. These all are seen as very spastic type in the case of quadriplegic CP. In the case of diplegic CP, we have hip flexors, hip adductors, knee flexor, ankle plantar flexor. Okay. Okay, now if the hip adductor is tight, if there is any tightness in the hip adductor, what we can see, if there is hip adductor tightness, then the seizuring gait can be seen in the patient. If there is tightness in the ankle plantar flexor, okay, if there is any stiffness in the ankle plantar flexor, what we can see, the during the gait pattern, there will be no foot flat. The patient will not able to flat his foot on the surface. So there will be equine position of the patient. It can also be seen. So these all muscles can be managed. These all muscles can be managed only by the stretching. So in the spastic CP, stretching is one of the very important tool for the management. Then ROM exercises, we have to go for the gentle ROM exercises. In the ROM exercises, if the patient is able to do active exercises, if the patient is able to do some active movements, we have to go for it, because the active participation of the patient is very important in the treatment, in the treatment or in the management of any case, ranging from the pediatric to the geriatric case. The active participation of the patient is very important. Why? Because during the active participation of the patient, especially in the case of the motor function disability, if the patient is able to participate actively into the treatment protocol, actively into the exercise regime, then it can lead to some positive feedback to the brain of the patient, to the central nervous system of the patient, and it can also re-educate the motor disability. It can also re-educate the muscles to do the motor functions very perfectly. That's why active participation is very important. Apart from the ROM exercises, we have to go for the weight bearing exercises. Weight bearing exercises in sitting, in standing. Standing itself is a weight bearing exercise, but still, so we have to go for the weight bearing exercises. We can also go for the quadruped position for the weight bearing exercise. Then weight shifting. Weight shifting is very important for the proper gait pattern of the patient. So we have to manage for the weight shifting of the patient. We have to do some exercises for the weight shifting too. Then slow and rhythmic rocking exercises, active trunk rotation of the exercises. We can also do bridging exercises, or the half bridging exercises to the patient. We can also do sit to stand, the transition from the sitting, a transition from sitting to standing. We can also use physio ball. On physio ball we can do different activities like jumping activities on the physio ball, like the rolling activities on the physio ball, like the we will place the patient in the supine lying on the physio ball. Then we will stable the hip of the patient, and then we will ask the patient to flex his spine. Okay, so we can do different activities on the physio ball that can lead to a proper alignment and the proper management of the muscles of the patient. Okay, now after this we can do reaching in supine. In supine we can do reaching. This reaching can be done by some activities too, like with some toys we can go for the reaching activities. If the patient is not able to, if the patient is not interested in the exercise regime, we have to go for some toys. We have to get some toys, and with the toys we can do the reaching activities in the supine. In Apart from the supine, we can do the reaching activities in kneeling position too. We can do the reaching position in half kneeling too. Okay, so this can also be done. Trunk flexion and extension on the physio ball, as I have already told you that on the physio ball we have to go for different activities. Okay, now rolling on the physio ball. Rolling is also very important. Gait training, I have already discussed about the gait training. And now positioning, I will discuss about this in the next slide. Till then, orthosis, AFO, ankle foot orthosis, supramalleolar orthosis can be used for the management of the deformities. If there is any deformities, if there is any orthopedic deformities in the patient, we can use for this ankle foot orthosis, supramalleolar orthosis, etc. Okay, now positioning. Let's discuss about the positioning of the patient. First, supine. Now each and every position have some advantages and disadvantages too, so here we will discuss both. In the supine position, advantage is we can begin early weight bearing. Early weight bearing can be started in the supine position. As I have already told you that weight bearing exercises are also very important in the case of cerebral palsy. So in the supine position, we can begin early weight bearing through lower extremity when knees flexed and feet are flat on the surface. Let me explain you with a line diagram. Here, just an example that this is the patient trunk, this is the hip joint, and here the knees will be flexed. So this is something like this, like this. Okay, this is this is the head of the patient and this is the hand. So something like this. In this position we can go for the trunk exercises for the weight bearing on the lower extremity. If we ask the patient to lift up his or her trunk, then the weight will be then the weight bearing part will be our leg and the upper trunk. So we can begin early weight bearing through lower extremity when knees are flexed and the feet are flat on the surface. Okay, after this, what are some disadvantages of the supine? In the supine it can be disorienting because mostly many childs get sleep. Many childs the level of arousal will decrease in the supine position. It can be disorienting because it is associated with sleeping. That's why this is the only disadvantage for the supine position. Now if you go for the side lying position, the advantage is it is the best position to promote functional activities like rolling and transition. During the transition between the supine to prone, we can go for the side lying position. From side lying position, the transition from the side lying position, the transition to supine and the transition to prone, both are very easy. That's why the side lying position is best position to promote the transition activities on the bed. The rolling activities can also be done very perfectly from the side lying position, and different functional activities can also be done here. Okay, now apart from this, the what are the disadvantages of the sideline? Here, shortening of upper trunk muscles make if the child is always positioned on the same side. For example, I have a patient and I always do the functional activities in sideline only by turning to the left side. Then this will be something wrong. This is something wrong because if the patient is always positioned on the same side, the upper trunk muscle shortening can occur, and it can again lead to different deformities and different conditions. It can also lead to some issues. Okay, so this is the disadvantage of the sideline. Then a prone. In the prone, we can begin early weight bearing through upper extremity in prone, like a prone on arm, a prone on elbow, etc. So in supine, the weight bearing was done with the lower extremity, but in the prone lying, weight bearing can be done on the upper extremity. it can also stretch hip and knee flexors, but there are a lot of disadvantages regarding the prone. If we are keeping the patient in prone for a longer duration, then the breathing can be difficult, breathing distress, the respiratory distress can be seen in the patient, or the lungs collapse even can be seen if the patient is kept in the prone for a longer duration. We have to restrict the patient to sleep in the prone position. We have to teach the family, we have to teach the attendant that we should not keep the patient in the prone position. Okay, now in sitting is one of the best activities to go for the functional activities and for the trunk muscle exercises. For sitting, it promotes the active head trunk control. In the sitting position, the patient will try to control his neck muscles, head, trunk. Okay, now weight bearing can also be done with the sitting. Side sitting promote trunk rotation. If we just modify the events of sitting and make it a side sitting, then it can also lead to the trunk rotational exercises. Okay, and if we are performing any activities, if we are performing reaching activities or many different functional activities can be done with the patient only in the sitting activities. So sitting activities is one of the best activities for the functional activities. Now what are the disadvantages? Here the child will need some support on the trunk, since the trunk muscles are very weak. Since the trunk muscles of the patients are very weak, the patient will not be able to maintain his or her upright posture through the trunk. That's why the trunk needs to be supported by any therapist or by any person. Here the child will unable to maintain the neutral position and the extension of the trunk, as the trunk muscles are weak. Again, the same reason, the child will unable to maintain the neutral position of the trunk or the extension of the trunk. The child will always be in the trunk of the child will always be in the flexion. The child will always be in the bending position. So we will need to support the trunk of the patient. Then quadruped position. Here in the quadruped position, the advantage is the weight bearing. Since in the quadruped position, the weight is performing uniformly on both the upper extremities and both the lower extremities. So quadruped position can be a very good position for the weight bearing. Apart from this, trunk works anti-gravity. The trunk muscles are working against the gravity in the quadruped position, so it can also influence the trunk muscles to work more well. The trunk muscles will here the trunk muscles are working against the gravity. It means that it is working against the resistance, so it will increase the strength of the trunk muscles, and further it can help the patient to keep his or her trunk upright. Now, disadvantage, the posture is difficult to maintain because of the influence of symmetrical tonic neck reflex. Here, posture is very difficult to maintain because of the symmetrical tonic neck reflex. I have already told you what is symmetrical tonic neck reflex. Here, in the condition of quadruped position, as we have already studied that in symmetrical tonic neck reflex, if the head of the patient is flexed, then the arm will also flex and the leg will extend. If the STNR is present in the patient, then if the patient is in quadrupt position, and suddenly and we all know that neck muscles are not working very fine. The patient is in quadrupt position, the neck muscles are very weak, so the patient will unable to maintain his or her neck position in neutral, his or her neck in the neutral position. Due to the weakness of the neck of the due to the weakness of the neck muscles of the patient will go for the cervical flexion, the neck flexion, and when the head will flex, automatically the arm will also flex and the leg will also extend, and the person will not be able to keep in the quadrupt position. That's the disadvantage of the quadrupt position, that if the patient is having the STNR positive, the symmetrical tonic neck reflex positive, we cannot keep the patient in quadrupt position for a longer duration. Now, at last, kneeling. In the kneeling position, it provides stretch to the hip flexors. Kneeling is one of the very important and one of the very critical position for the child with CP, especially in the case of the cerebellum lesion, especially in the case of the ataxic CP, we can go for the kneeling too. But in the case of a spastic CP or any other CP, kneeling is very important again. It can help to stretch the hip flexors. Whenever the patient is in kneeling position, the hip flexors are stretched, the hip and pelvic control can be developed. The patient will try to maintain his or her hip and pelvic posture during this position. That's why hip and pelvic control can also be developed during this kneeling position. And with kneeling, we can also progress it, we can also complicate it with reaching. The patient is in kneeling position and we can also go for the reaching activities. We can modify the kneeling as we can also go for the knee standing of the patient. Again, the patient will be in the knee standing and we will do reaching activities with the patient with the toes. Okay, after the knee standing, we can also go for the half kneeling of the patient one by one, first for the left side and then for the right side. So half kneeling can also be very complicated. So we have to complicate the exercise regime. We have to progress the exercise as per the patient's recovery stage. Okay, now this can also help in transition between different postures, like if we are telling the patient to from sitting to standing, or in the different posture, the kneeling can also help. What are the different what are the disadvantage of the kneeling? In the kneeling, the posture is difficult to maintain. If the patient is maintaining the posture for a longer duration, then we can progress it to some other complicated exercise. But still, the kneeling posture is somewhat difficult to maintain for just a child. Since cerebral palsy is a condition of a child, so in the children, this kneeling position is somewhat difficult to maintain. Okay, so this is all about the physiotherapy management and the physiotherapy assessment of the cerebral palsy. Okay.